Hey everybody, Dr. John here, and in this course we are going to be covering a very important topic called Hylenex. Hylenex is the drug you need to be an expert at using and hope you never have to use it in an emergency. So that's what we're going to talk about today. By the time you finish these modules, you will have a complete understanding and command of this molecule, from the science of how it works to the art of how to use it. You're going to learn the exact protocols to save a patient during a vascular emergency and the precise dilution recipes to artistically correct migration or lumps without ruining your good work. We're going to cover the math, the methods, and the business strategies you need to stock and use this tool effectively. Hopefully, you're going to leave here with the confidence to handle any complication that comes your way. You wouldn't drive a car without insurance, would you? And you would certainly not drive without brakes. So why would you inject a face with filler without Hylenex? It is your safety net. If you don't have this on hand, you are practicing without that safety net. And in this industry, that's not an option. Think of Hylenex like an EpiPen for aesthetics. You hope you never have to use it for an emergency, but the moment you need it, that's the only thing that matters. So we're going to talk about vascular occlusions, or VOs for short, later in this course. It's the scary part of the job, but here's the secret to overcoming that fear: preparation. Confidence doesn't come from ignoring the risk. Confidence comes from knowing you can handle them. And let's be absolutely clear about the standard of care. If a vascular occlusion happens and if you inject long enough, it is a risk and it could catch up to you. And if you don't have Hylenex available to reverse it, that's negligence. It's that simple. By taking this course, you are ensuring you never find yourself in that position again. So now that we understand the why, we need to understand the what. We need to understand the tool that we are using. So, what is Hylenex? Chemically, it's called hyaluronidase. It is an enzyme. Its specific job in nature is to break down hyaluronic acid, or HA for short. Imagine the HA molecule as a long chain. It's a sugar molecule that holds water and gives structure to the skin in the fillers that we inject. Hylenex works by hydrolyzing this chain. It targets the bond, that link that holds the chain together, and snips it like a pair of scissors. Once that bond is broken, the filler loses its structure. It turns from a gel back into a liquid that your body can easily absorb and clear out of the way. Now, here's a critical distinction you need to know. Hylenex is human recombinant. What does that mean? It means that it's engineered in a lab to be bioidentical to the enzyme your body naturally produces. So, why does that matter? In the past, we've used hyaluronidase derived from animals, bovine or ovine. These products carry a risk of allergic reaction because they are foreign proteins. Hylenex, being a human recombinant, has a significantly lower risk of that allergic reaction, but it's not zero. This is why it's the gold standard for emergencies. In a high stretch moment like a vascular occlusion, you don't have time to do a skin allergy test. You need to act immediately, and Hylenex gives you the safety profile to do that. So, what is the chance of someone reacting to Hylenex? It's about 1 in 2,000, believe it or not, which doesn't sound like a lot, but when you multiply that 1 in 2,000 by millions of people in the United States, there are millions of people that will react to Hylenex. So, in a non emergency situation, we should be testing for that allergy. We do that with a little bleb test on the forearm just to see if the patient reacts. In an emergency, you're going to take the chance. There's a 1 in 2,000 chance they're going to have an allergy. It doesn't matter if they do have an allergy to the medication because we have a vascular emergency. So what are we going to do? We're going to inject the Hylenex and deal with the allergic reaction if it creeps up. So just because it's a low risk doesn't mean it's a no risk. However, in an emergency, we're going to go right at it. So let's talk about how Hylenex moves in the body. Its onset is immediate. As soon as it touches the HA, it starts to break it down. Its half-life is very short, about 2 minutes in the blood. However, the enzymatic action, that breaking of the bond, is permanent for filler that is present. It doesn't wear off and let filler reform. Once it's cut, it's cut. So finally, let's address a common fear patients and providers have. Will this eat my natural skin? And the answer is nuanced to some extent. Yes, Hylenex is an enzyme. It doesn't know the difference between filler hyaluronic acid and your natural hyaluronic acid. It will degrade some of the native hyaluronic acid in the area that you inject it. But, and this is the key, your body's resilient. Your body's constantly producing new HA. Any natural HA that is degraded will typically be restored with your body in a day or two. The filler, however, does not regenerate. So the net effect is that the filler is gone and the tissue returns back to normal. So you have the mindset and you now have the molecule. You know why you need it and you know how it works. In the next module, we're going to break down the two very different ways you're going to use this tool, the emergency versus the aesthetic correction. So let's get into that. All right, let's start this new module. We are going to look at how we actually apply what we just learned about hyaluronic acid. And to do that, we have to separate our clinical thinking into two very different buckets, the emergency bucket and the aesthetic bucket. So what do I mean by that? The way you think, the way you dilute your product, and the way you inject will be completely different depending on which bucket you are standing in. Let's start with bucket number one, the emergency situation. This is a vascular occlusion or a VO. In this scenario, we throw the art out the window and we aren't worried about the shape of the lip or the symmetry of the cheek or the area that we filled. We are worried about tissue survival. When a vessel is blocked by filler, the clock is ticking and you are in a race against necrosis. In an emergency, our mindset is flood the field. We aren't looking for a precise tiny dose. We want to saturate the entire area with Hylenex to ensure we dissolve that blockage as fast as humanly possible. Our goal is one thing. Let's get the blood flow going again. All right. So that's the emergency bucket. Now let's switch gears and go to bucket number two, the aesthetic correction bucket. This is what I call the eraser or the sculptor bucket. This is for the patient who comes in with like filler migration or that filler mustache from filler that migrated from the lips elsewhere. Or maybe they have a Tyndall effect where it's really superficial and it looks gray, right? Or maybe we got a bump or a lump somewhere. Or perhaps it's just a patient who feels overfilled and wants to look like themselves again. All right. In this bucket, we adopt a completely different philosophy. And to borrow a phrase from my colleague, Dr. Gold, we start low and go slow. We don't want to flood the field here. If we do, we might take out too much filler and leave the patient feeling hollow or deflated. Instead, we use specific dilution recipes to gently sculpt the area. We want to find the lowest effective dose to fix the problem while preserving the good work that you've already done. And it's the difference between using a sledgehammer to knock down a wall and using a fine chisel to carve a statue. Both are useful tools, but you have to know which one you're holding. All right. So, which bucket are you in determines the recipe for mixing the Hylenex, which is exactly what we're going to cover in the next section. We'll talk about exactly how much dilutant to add to your product to get the perfect concentration for the job at hand. All right. So let's move on to the two technical sides of the two buckets. So let's start to talk about vascular occlusions or VO. I'm not going to sugarcoat it. A VO is a crisis. It is the most feared complication in the aesthetic industry. But let me tell you something important. Knowledge and preparation will reduce that fear. Panic is the enemy of a good outcome. And panic only happens when you don't know what to do. By the end of this session, you're going to have a clear step-by-step battle plan so that if you ever have something like this happens in your chair, you're not going to panic. You're going to act. All right. First, you have to recognize it. You can't treat what you don't see. So what are the immediate signs that scream danger? The first is pain. Now, injections hurt, sure, but VO pain is very different. It's often disproportionate, burning or aching, and it persists even more when the needle's out. Patients will have an impending sense of doom. They'll just know something's wrong. They'll get diaphoretic. Things like that should cue you in that, hey, we got something bad brewing here. All right. The second immediate sign is blanching. The skin will turn white or pale because the blood supply has been cut off. It looks like blood has literally been drained from the area. All right. And then there's going to be some delayed signs. If your patient calls you hours later or sends you a photo the next day, look for livido reticularis. This is a mottled fishnet-like pattern of the skin. It can look dusky, gray, or purple. If you see this, the tissue is starving. All right. So how do you confirm if the patient is having a VO or if it's just bruising? All right, what do you do? Well, you do a cap refill test or CRT. All right, so here's how you do a cap refill test and how you do it properly. First firmly press on that area with your hand for 3 to 5 seconds and then release. Then immediately do the same thing on the non-injected side, maybe the other cheek or the other side of the lip, or the lower lip if it's in the top lip. You get the picture. In healthy tissue, that remember from school that pink color returns in 1 to 2 seconds. In a VO, that return is either sluggish or it doesn't happen at all. It's slow. If you see a delay compared to the healthy side, you've got to assume we've got a problem here and that VO is present until you prove otherwise. All right. So let's talk about the protocol. If you suspect a VO, we shift immediately into bucket one thinking, emergency bucket. We are going to flood the field. Throughout any thought of microdosing, do not worry about ruining your aesthetic result. Your only goal is reperfusion of that tissue. All right, so let's talk protocols. Let's talk the protocol for an emergency situation. All right, and these are the orders and steps you should go into. And remember, this is all typed up in the course documents as well for you to download and print. And I recommend printing them off so that way in an emergency, you have step-by-step ways of following the protocols. All right, so what's the first thing you're gonna do? If you're a registered nurse, first thing you're gonna do is notify your medical director. Okay, that's the first thing you're gonna do because they're the ones ultimately responsible for getting you through this situation. So call the medical director, let them know what's going on. I don't text, just call. They don't pick up, that's fine. Move on to step two, leave a message. This is an emergency. I need you to call me back ASAP. All right, so that's number one. Number two, you should have already obtained a consent prior to your filler treatment to initiate a emergency protocol. So in your filler consent, there should be a line or two that says, in the event of an emergency, you understand that I will be flooding the area with the antidote Hylenex and that all treatments, all the treatment up to that point will be negated and that you will no longer have the results of the filler, et cetera, et cetera, et cetera. You can put a few lines of consent into your filler protocol. So make sure you have a consent on file. If not, then you got to scramble and find a consent during an emergency and have them sign off on it. So always have that consent signed with your filler consent. Number three, where the vascular occlusion is determines your next steps. If the patient is having vision disturbances, you have to assume that some of that filler ended up into an artery that's feeding the eyes. And that's a different type of an emergency. So your next step at this point, if there's visual disturbances, is you have to notify the closest emergency room and arrange transport to get them to that emergency room. Okay, you're going to be talking with the charge nurse who might then patch you into an optometrist, and ultimately it's the optometrist that's going to be going in and injecting Hylenex behind the eye. Okay, get them coming. You have 90 minutes to save that eye. If we don't get blood flow back to the eye, they're going to go blind. So really, really important that you start that process going. Now, does that mean you're going to wait till the ambulance shows up? No, the ambulance is going to be there for 5 to 15 minutes potentially. Maybe you're 20, 30 minutes away from a hospital. You're going to have to go to the next steps, but get that process going. The hospital's got to find an optometrist to come in and treat the patient. When you're on the phone with the hospital, ask them, do you have Hylenex in stock? Because if they don't, your supply is going with the patient. Okay, they're not going to be able to scramble it up in enough time. All right, so get the hospital notified. Now, if they don't have visual disturbances, do you need to notify the hospital immediately? No, you do not. All right, so now we're going to prepare the solution. All right, remember, Hylenex comes in 150 unit vials, single dose vials, and they usually come in packs of 4. So what I will do is I'll grab a fresh pack of 4. Always make sure you have 2 full packs at the minimum in your supply refrigerator. Remember, and Hylenex is refrigerated. So you're gonna pull out that box of 4, and in that box of 4 is 600 units of Hylenex, okay? And I'm gonna get a 5 cc syringe, and the first thing I'm gonna do is I'm gonna draw up 1 cc of lidocaine. Why lidocaine? Lidocaine is a vasodilator. Make sure it's lidocaine by itself, not lidocaine with epinephrine. Epinephrine is a vasoconstrictor, okay? And you definitely don't want to constrict the blood supply. We want to increase the blood supply to our area. So we're going to draw up 1 cc of lidocaine, And then we're going to drop the 4 cc's of Hylenex. And then that solution is going to be 5 cc's, and it's going to have a total of 600 units of Hylenex in it. All right. And so now you have a 5 cc syringe with your solution, and that's what you're going to take to the patient for administration. I like to use a 27 gauge needle in this situation. So I'm going to screw on a 27 gauge needle. If you have a 30, it's fine. Why 27? I can get it in there a little bit faster. I'm not pushing really hard to try to get it out. All right. So now we have our solution. We're going to take it to our patient. So are we going to be doing a allergy test on this patient at this time? I wouldn't recommend it. Some protocols will say to do a little bit blood test. However, it's going to take 5 minutes to see results. And the clock is ticking. So let's forego the allergy test. If they have an allergic reaction, we'll deal with it. That's what an emergency room's for. The more important thing is let's get this vascular occlusion out of the way. All right, so now what we're going to do is we're going to take that syringe and it's going to accompany us to the patient. Now, before we start administering the area, what do? I get a 325 milligram aspirin tablet that's chewable. We have them pop it in their mouth and we have them chew that really quickly and get it going. Why? It's a blood thinner. Okay, it's going to help the blood get around the clot. It's going to help perfuse the area. So a little bit of aspirin. Always have a vial on hand. It costs you $4.99 at Walgreens. Go get a bottle of it, and hopefully you'll never have to use it. Okay, but aspirin is really, really important. All right, so now what we want to do is we want to inject about 500 units of solution into the area. Now remember, you have 600 units in 5 cc, so roughly 125 units for every cc. So what do? I will inject around 4 cc's of fluid into the immediate area where you suspect that vascular occlusion is. So how do you find where the vascular occlusion is? Remember, let's say you're doing a jawline injection and you inject down here and you happen to hit the facial artery. Is this where you inject the Hylenex? Well, maybe if you see that entire track start getting modeled, okay? But what if the track's getting modeled up here and everything right here looks good? If the track is high, inject where you suspect the vascular occlusion is. It's not going to be down here. You can flood this whole area, and you're highly likely not to get that clump of filler that maybe was injected here, but traveled up the artery and got clogged near the eye, or maybe the tip of the nose, or maybe went into the inferior labial artery and you're seeing the lip get modeled, or the superior labial artery. Anyways, where you see the modeling is where you want to inject. So you want to use your anatomy, what you learned in anatomy, and go backwards from the model backwards. And then maybe inject 1 centimeter or 2 centimeters in front of that area, and then just start flooding the area with that. I'll take that 27 gauge needle and I'll go in and I will just fan it out. Am I trying to inject into the artery? No. Why? It's virtually impossible. You're not going to be able to find that artery perfectly and get it into the tissue. So we know that Hylenex will absorb through the vasculature. It will go through the arterial wall and it will break down it will break down hyaluronic acid through the membranes. So as long as you flood around the artery, it will absorb into the artery and start breaking that down. Okay, so we're going to inject that, and we're going to be injecting around 4 cc's. I'll fan out the whole area, and we'll just put a big blob of it in that whole area. If I suspect that the occlusion's here, and maybe there might be another one up here, I might inject 2 different spots with that solution. So we got the aspirin on board. We've got the Hylenex injected into the area. Now what do? Now we're going to start massaging the area. Okay, I like hot compresses. Put hot compress down. That dilates blood vessels, and then massage that area and work that filler in, or that hyaluronidase into the area and help it work into the tissues. Remember, it has a very short half-life, so you have to be quick with it. It's going to be eating up native hyaluronic acid, but it's also going to be eating up the problem stuff as well. So start massaging the area. How long are you going to be massaging for? I like about 1 or 2 minutes. So you're going to be massaging for 2 minutes, and then you're going to put a warm compress down for 1 minute. And then you're going to repeat that cycle of massaging a warm compress for roughly 4 times. So you got about 10 minutes of work here, just massaging the area. Okay, now hopefully what you're seeing is more tissue getting pink, and you're going to start seeing blood flow. hopefully during this process, but we're going to be doing that for some time. All right, so now we've done our massaging protocol. Now what do? We're going to check for cap refill again. So just like I told you before, go to a non-affected side of the face, put your finger, and on the affected side, lift up. Do we have similar cap refill? Is one side sluggish? Is one side not? Did we get rid of the occlusion? If we did, great. Monitor the patient for another 45 minutes. Maybe you broke down that clump into two and now it went further up the artery chain and split and went to the tip of the nose. Okay, we've got to look for other areas that facial artery, if you injected the facial artery, innervates with or feeds with, and so we need to monitor our patient. Okay, so um, and keep them in the chair for a minimum of 45 minutes after the vascular occlusion. Let's say you do a cap refill test and you still see we have an occlusion. What do? You're going to repeat those steps again. You're going to go back to the fridge. You're going to grab another box of hyaluronidase. You're going to mix it up, and then you're going to be injecting it again. All right. Remember, you still have 125 units from the first dose. Now we've got another 600 units. So we're going to, maybe this time we'll do 3 cc's. And then that way we have one final dose of 3 cc's of fluid to do a third and final injection into the area. Okay. But you're going to repeat those steps. When I say repeat those steps, inject or mix, inject, and then rub the area for that 10 minutes. 2 minutes on, 1 compress for 1, 2 minutes on, 1 compress for 1, and then we're going to check cap refill again. If we still don't have cap refill, we're going to go through the process again. You're going to repeat that process every 20 minutes as necessary, okay, or until you run out of Hylenex. Now, if we don't have vision changes and we've been at this for about 2 hours and we still don't have cap refill, now we're notifying the emergency room. We're going to call them. We're going to talk to the doctor over there and say, hey, I'm sending you a patient. I suspect a vascular occlusion. I have negative cap refill on the area that I injected hyaluronic acid filler. I have given 3 doses of hyaluronidase, and I have not gotten blood flow back into the area, and so I'm sending them your way. Do you have hyaluronidase on stock? Yes or no. If they say no, say I am out. I just used my whole contents of hyaluronidase, so you need to acquire some from a local pharmacy or something like that. All right. Most hospitals, most emergency rooms do have it on stock, so I wouldn't worry about that. But if they don't have it, they're going to need it. Okay. And then you're arranging transportation. Then an ambulance comes, picks the patient up, goes over. You give your cell phone number to the provider. They will be calling you. Hopefully by this time, our medical director is on board and you are communicating with the medical director too of all these problems that have popped up. All right. So that is the protocol for emergency reversal, both vision and non-vision areas. Okay, it's a lot less emergency if it's in a non-vision area. You got lots of time to revascularize that tissue, but with an eye, you got to be quick. Okay, so that's the emergency reversal protocol. Print that off. Go through those steps routinely. There's modifications your medical director might want you to do. Maybe they want to put their patients on nitrates or sildenafil, which is Viagra. Viagra is a vasodilator as well. Having the patients breathe through their nose will release nitric oxide, vasodilator. It also helps calm them down. There's all these other little nuances you could potentially do as well. But that's the hard and fast rule. Give them some aspirin, get that Hylenex in the area, massage, warmth, and you're going to be doing what you're supposed to do. Now, that's an emergency. That's scary. Is an emergency considered malpractice? No, because in your consent, there is a risk of vascular occlusions. It is a known risk. You've gone over that with your patient. Hey, this is pretty rare, but it could happen. What is malpractice is not having Hylenex on store and not trying to reverse the problem. Okay, as long as you try and you do everything that evidence-based says, you're not doing malpractice. Malpractice is not doing anything. So that's my takeaway for the emergency reversal protocol. All right, in this module, we're going to step out of the emergency room and into the art studio. We are done flooding the field. Now we need to put our thinking caps on. When we use Hylenex for aesthetic correction, we adopt a philosophy like my colleague Dr. Gold often uses for peptides: start low, go slow. every patient is different. Correcting a migrated lip or a puffy tear trough requires a gentle touch. If you use the sledgehammer approach here, you're going to dissolve not only the bad filler, but yes, the good filler as well. And you're going to potentially strip away too much of their natural hyaluronic acid, leaving them looking hollow or deflated, or needing to do another filler treatment at their cost in the future. So, how do we control the power of the enzyme? We do it with math. We control it through our reconstitution recipes. Your standard vial of Hylenex contains 150 units of the enzyme. How much saline you add to that vial determines the strength of your eraser. So I'd like to break it down into these three specific mixes. First, we're going to talk about what I call the eraser mix. This is high concentration Hylenex. And so what do? I just draw out Hylenex straight from the vial, which will give you 1 milliliter of fluid with 150 units of Hylenex in it. And then you can use this for those really hard, stubborn nodules for when you need to completely remove like a bolus of filler that just shouldn't be where it is. It's strong and it works fast. If you want, you can dilute it down with a little bit of lidocaine, but you're not going to be as concentrated as you normally are. And this method works really well, not necessarily with a whole cc, but maybe with just straight lidocaine that you're doing it like a small dot with. All right. Second, we have what I call the sculptor mix. This is medium concentration. Here, you're going to add like 3 to 5 milliliters of saline / lidocaine to that 150 units of Hylenex, and you're going to dilute down the enzyme significantly. And this is what I use for fixing, large areas like duck lips or migration outside of the perioral area. And you can inject this along the vermilion border to gently tuck in that lip back in without deflating the entire volume of the lip. And then third, we have what I call the blur mix. This is very low concentration. You take that 150 units of Hylenex and add 10 cc's of saline to it. And think of this as like a weak wash. Why or when would we want to use this? This is for those high risk, delicate areas, specifically like tear troughs, I'm thinking, or maybe you did some buccal cheek augmentation and you want to flood that whole area and get rid of all that kind of stuff. Tear troughs, if they have those tindling effect underneath their eyes, I don't necessarily want to hollow them out, but I do want to soften that whole area. Okay. And the blur mix allows me to do that very safely, just taking it down a notch. All right. All right. So now let's talk about the elective reversal protocol. So when would you use an elective reversal protocol? Anytime the patient's unhappy with the results of filler. So check that one box. That happens from time to time. I would say less than 5% of my patients will electively remove all the filler that we put in. Tyndall effect, almost always we'll do that. Migration, we will do it. With my lip filler patients, I recommend that once every 2 to 3 years, we reverse regardless if they need it, because filler builds upon filler builds upon filler. And if you want natural looking lips, you should be dissolving your filler on your patients every 2 to 3 years, especially in the lips and the movable areas. Or maybe there's a bump or lump somewhere and we just got one tiny little dot that we've gotta fix. Okay, so those are all the different scenarios for filler. So let's start off with a protocol for lip reversal. Okay, they got filler in their lips, it's been a few years, it's time to reverse it. What do we do? First thing with any elective procedure is you're going to get a consent form. Now, they may have already signed a reversal consent previously with your filler consents. However, you might want to have a separate consent for for an elective Hylenex that might say a few things that are different. Like, hey, this is an elective procedure. You're going to eradicate the treatment we've done previously. There are some risks. You might have an allergy to this. Expect bruising, swelling, that sort of thing. Okay, are you worried about vascular occlusion with Hylenex? No, like I don't talk to them about that. Infection, maybe you might have that on your consent. But bruising, swelling, and reversal of the treatment that they've had previously would be very important things on there, as long as the allergies. Anytime you do an elective Hylenex, the first thing you're going to do is you're going to get that jar of Hylenex. You remember they come in 150 units per vial, and I take an insulin needle and I will pull up 1 or 2 units of that medication. or 1 to 2 volumetric units of that medication in an insulin syringe. And then on the forearm, you're going to do a bleb. Okay, you're going to go right underneath the skin and put a little bleb and tint that skin. Mark it with a dot so you know where that bleb is, and then talk to them about consents and do all that kind of stuff and give it 5 to 10 minutes to sit down. Then before you proceed and before you go mix up your solution, what are you going to do? You're going to look at that area and see if they're reacting. If it's bright red or if it looks like a rash or something like that, they are reacting to Hylenex. This is not the treatment for them. Okay. But if there's no reaction, go ahead and get the solution prepared. What do I do for my lip reversal is I'll just use 1 vial of Hylenex, which is 150 units. And I will take that vial and I'll draw it up into a 3cc syringe. I'll add to it a little bit of lidocaine because hyaluronidase kind of burns a little bit and the lidocaine kind of numbs the area. So I'll put in, a half a cc of lidocaine, maybe another cc of bacteriostatic saline. And I'm going to get a dilution volume of roughly 1 cc Hylenex, 1 cc of bacteriostatic saline, a half cc of lidocaine. So there's my about 2.5 cc's of volume in my solution. And if I'm doing lips, I'm injecting half of that in the top lip and half of it in the bottom lip. Will I eradicate all that Hylenex in immediately? Or will I eradicate all that hyaluronic acid filler immediately? And the answer is no. It's often will take 2 to 3 treatments. And I space those treatments about a week apart. And then I'll instruct the patients to rub their lips, 3-4 times for that first hour and then be done. And what does that do? It mixes that Hylenex in. It'll go and break down, it might break down the area, the filler in this area, but by massaging it, you could push what's left over into other areas for dissolving of the filler. Okay. And then I have them follow up in a week or 2, and I see what's left. And you'll notice very quickly the areas that are left are going to feel harder, they're going to be more inflated, and then you'll do the exact same protocol, and I'll go in and I'll dissolve out the next batch. So that's what I would do with lip filler. About 2.5 cc's, 1.25 in the top, 1.25 in the bottom, 1 vial of Hylenex, and see what happens. Follow up a week later. Now let's say it's a small area. Let's say we just have like a bump above the lip that you can see the filler has migrated. This happened to my wife about 6 months ago. We noticed that some of the filler we had put in her lips had migrated. And so what do? Do I mix up a whole vial of Hylenex? No, I don't. Remember, I'm going to do an allergy test, but I don't need a whole lot. I'm just treating one tiny little area. So I'll get an insulin syringe. I'll draw up, let's say, 20 units of Hylenex, or to the 20 line of the insulin syringe. I might drop a little bit of lidocaine in the remainder of that. And then what I'll do is I'll mix that up in the syringe and I'll just inject that dot and I'll just put a little bit of solution into that dot, and then I'll rub it. And you'll see it break down pretty quickly. And I'll look and see, okay, do I need more? I might put another little dot in there. All right. And just slowly work on that spot. Have them come back next week. Did we get rid of that dot? If not, go back in and do some more of it. All right. And so you don't need a lot. I mean, maybe 5 units of Hylenex is all you need if it's a tiny little dot, or 20 units of Hylenex if it's a big dot. Okay. So you can be very precise with it. Again, allergy test. Let the patient know it could take multiple treatments. Is a granuloma considered malpractice? No, it's a known complication. Okay. Granulomas happen. They're rare, they happen. Now, what you don't want to do is, if you're just injecting one fine point, you don't want to flood the entire area, because if they're overall happy with their lips, do you want to dissolve all the lips out? No. So very fine tune in that area, and then just massage that area. Don't make sure you're not massaging into the other areas that you don't want to inject. Okay, so you can be very fine tuned with Hylenex as well. And then there's in-betweens, right? There might be a larger area of migration, like above the lip, but you try not to hit the lip. In those instances, I might inject a little bit higher, try not to get it into the vermilion. But in my experience, once you're dissolving, large areas, it's going to leak into other areas, and plan on some filler down the road. Finally, and this is so important, you have to manage your patient's expectations. Okay. Unlike the emergency protocol where we keep injecting until it's fixed, aesthetic correction takes time. The enzyme can work instantly, but the tissue response, that swelling and that settling, takes 24 to 48 hours. Okay. Tell your patient something like, it might look worse than it before it looks better. Or and don't chase perfection when sitting. Inject some, send them home, and follow up with them next week or 2 weeks. Okay. It's going to be a process, and oftentimes it could take 2 or 3 sessions to get it done right. All right, so now you have your recipes and you have your techniques, you have your protocols. In the next module, we're going to get hands-on. We'll walk you through the practical skills of how to mix this stuff, how to store it, and how to manage the side effects that come with using this awesome medication that we call Hylenex. All right, we've covered the science, the protocols, and recipes. Now let's get our hands dirty. In this module, we're going to walk you through the practical skills you need to actually prepare and handle Hylenex safely. First, let's talk about reconstitution. You can't just pull Hylenex off the shelf and inject it. You have to mix it, unless you're just trying to get a very, very tiny spot. And just like we discussed if you did our IV training, your technique matters. You're going to need your vial of Hylenex, your syringe, and your diluent, lidocaine bacteriostatic saline. Now, a quick note on the diluent. You have lots of choices here. You can use standard normal saline, you can use bacteriostatic saline, you can use lidocaine with or without epinephrine. Why? Because it works really, really well. I prefer bacteriostatic saline. It has a little benzyl alcohol in there. And not only does that benzyl alcohol act as a preservative, but it also has a mild anesthetic effect. It stings less. Okay. And when you're injecting it into a sensitive area, like maybe around the mouth or an area like maybe underneath the eyes, um, every bit of comfort helps. All right. So here's the process. It's really simple, but it must be precise. First, pop off the top of your vials. Second, swab the hub. Third, draw up your diluent first, not the Hylenex, the diluent first. I always start with the least medication type diluent, so saline. Why? Because if I'm going to pull that needle out of a saline mix and put it into a lidocaine mix, I don't really care that a little bit of saline got into my lidocaine bottle. I do care if I do it the opposite way. If I draw up some lidocaine and then go into my saline vial, I don't want any lidocaine in my saline vial, right? So I start with the saline, I draw up what I want in saline, then I'll go to the lidocaine, I'll draw up what I want in the lidocaine, then I'll go to the Hylenex, and then I'll draw up what I need in the Hylenex. All right? And that's my technique, whether I'm doing a small diluent or a large diluent like the Blur, I'll do it in that process. Then what we're going to do after we've got our diluent drawn up, then we're going to go into the Hylenex vial and we're going to draw out the Hylenex that we need. And here's the most important thing. Leave a little air bubble in that syringe, okay? And that little air bubble, what you're going to do is you're going to invert that syringe up and down, and that air bubble is going to go from the top to the bottom, and it's going to be mixing up your diluent and your Hylenex. Then when I'm done, I'll invert that syringe and I'll squeeze all the little air out, and I've got a nice mixed syringe of my concoction, okay? And so that's how I go about it. Remember, Hylenex is an enzyme. You know, an enzyme is a type of protein. And if you shake it violently, like a martini, you're going to denature that protein and destroy it, or if you heat it up, right? You want to gently swirl or invert that bubble until everything is fully dissolved and we've got a nice uniform concoction. Let's talk really quick about storage. Remember, Hylenex comes refrigerated and you have to keep it refrigerated. If you don't, it will go bad. All right. And it has a really long shelf life. Like most of the Hylenex I buy has a 1.5 year, 2.5 year long shelf life. So I keep it in my fridge until it goes bad. You're going to find that when you have Hylenex, you're mostly throwing it away from expiration versus using it. The only time I use it in my practice really is for corrections. Okay. I've never had to do it in an emergency, but I'm ready for when it happens. Okay. But you want to make sure you keep it in refrigerated, the same refrigerator you might store your tox in, or some of your other medications like semaglutide or tirzepatide as well. All right, so that's what I have to say about storage. Now, finally, let's talk about managing side effects from Hylenex. We already know Hylenex is a human recombinant, so the allergy risk is very low compared to the old Hylenex we got from animals. But low is not zero. Anaphylaxis is possible. So if you see signs of a severe reaction, trouble breathing, hives, swelling of the throat, you treat it just like any other emergency. Obviously, stop the injection unless we're in an emergency situation. And then if you have an EpiPen, you can grab the EpiPen and inject it. I always keep a little bit of IV Benadryl on hand so I can give a quick IM shot of Benadryl. Or if you have vascular access, you can push some Benadryl into the vasculature. But you need to be ready for this. Obviously, if you have anaphylaxis, we're calling 911. That's going to be step number one, initiate the emergency protocol. But while you're waiting for them, hey, let's get some Benadryl on board at the minimum, okay, or an EpiPen. The much more common side effect that you need to worry and warn your patients about is what I call the prune effect. Remember, Hylenex eats hyaluronic acid. It doesn't distinguish between the filler or the natural hyaluronic acid in your body. So for about 24 to 48 hours, the injected and treated area, they're going to look deflated because all that natural hyaluronic acid, which is volumizing, is gone. And they're going to look wrinkly and dehydrated, kind of like a prune. All right. So if you don't tell patients about this, they're going to really freak out when they see their face the next morning after a treatment. And it terrifies them if they're not expecting it. So be a good steward of them when you're injecting Hylenex and let them know, hey, you might shrivel up for a day or two, but your body's going to naturally, grow back that hyaluronic acid and you'll be fine in a couple of days. Now, make sure you educate them up front. Say something like, your skin creates new hyaluronic acid every single day. This enzyme will clear your filler permanently, and it's going to take a little bit of time, a couple of days, for your body to replace its own natural volume and get you looking back to the way you're supposed to look. So just reassure them. Tell them not to judge the result until after that period of time. So now you know how to mix it, you know how to store it, and you know how to talk to your patients about the side effects. And what we're going to do next is we're going to move into the next module, and we're going to talk about the business side. How do we stock this? How do we charge for it? How do we get our hands on it? How do we handle the delicate situation of dissolving another injector's work? So let's talk business. All right, we have covered the science and the skills on Hylenex. Now let's talk about the business side of Hylenex. How do we monetize Hylenex, or do we monetize Hylenex? First, let's look at your inventory. You need to think of Hylenex not as a product you sell, but as an insurance policy you buy. And this is a hard and fast rule in my clinic. You must have enough Hylenex on hand to treat a full-blown vascular occlusion before you inject a single syringe of filler. And what does that look like? It's not one vial tucked away in your refrigerator. If you have a crisis, you're going to need a lot of it. You might go through 4, 6, 8 vials in a single session. If you run out halfway through a reperfusion protocol, you're going to be in big trouble. So my rule is a minimum of 8 vials in stock at all times. So that's 2 cases of 4, right? Yes, I understand that this stuff expires. Yes, I understand this stuff isn't necessarily cheap, okay? But you need to factor that waste in your cost of goods for your refillers or for your fillers. Raise your filler price by $5 if you have to, but never, ever, ever get caught empty-handed without having that in stock. All right. So that's what you got to have in stock. How much does Hylenex cost? I see it priced from anywhere from $250 to $400 for a vial for a box of 4. Okay, so roughly a 600 unit case will cost you, between that $250 and $400. Okay, so each little vial is going to be 75-ish to $100. So should you charge for it? Let's talk about it. Let's talk about charging for it. This is where it can get a little tricky. And I break this down into 3 different scenarios. Scenario A, this is when you are correcting your own aesthetic work. Like maybe you screwed up. Maybe a lip migrated a little bit or a tear trough is a little puffy. In my practice, I usually do this as a complimentary service recovery. Okay, I want the patient happy. I didn't hit a home run. Maybe I only hit a base hit. Okay, so what am I going to do? I'm going to fix my mistake, for lack of a better word, to give them their perfect result. Right. And at most, I might charge a nominal fee to cover the cost of the product, but usually it's on the house. It's just the cost of doing business. The other thing it does, a little side note, is by using it in that manner, it allows you to keep your inventory fresh, right? Remember, this stuff's going to expire at some point in the future. Most of my Hylenex I throw in the trash because I don't use it. So giving it away for free every now and then, you're going to have to buy it again eventually anyways, all right? So that's scenario A. Scenario B, this is the vascular occlusion on a patient, okay? Do you want to charge for this? Absolutely not. This is a safety emergency. You treat it until it is resolved at 0 cost to the patient. You are saving their tissue and you're saving your reputation. So do not charge for it. I won't even charge them for the filler I just injected. Okay, even though in my workup, I will tell them, hey, if there's an emergency, I have to reverse the treatment that you just paid for. And I use those words specifically, right? But do I end up charging them for it? No, I usually just eat the filler costs as well. I haven't had to yet, but when the event happens, I'm not charging them for the filler. I want that patient out the door, understanding an emergency happened, but they didn't cost them $700 in the process. All right, so that's scenario B. Scenario C, and this is the most common one you'll see. A patient comes in from a clinic down the street, or they've been your patient for years, and maybe they've had Botox or some other treatments at the clinic down the street, and that filler has migrated, and we got bumpy lips, bumpy cheeks, and they want you to fix somebody else's mistake. At this point, if it's somebody else's mistake, it's your premium service. And do not undervalue this. You're not just injecting Hylenex, you're diagnosing and correcting a complication somebody else created. So you perform a full consult, you assess the anatomy, and you charge for your expertise. In my practice, this is a billable procedure, and I usually charge between $250 and $500 per session. Okay, but there's a catch. The moment you inject that Hylenex, you own that patient. You own the complication. If they had an underlying issue you didn't see, it's now your problem. So charge accordingly for that liability. If you're going to fix somebody else's problem, that problem becomes yours. If you don't want to fix it, you tell them, hey, go back, have the other provider fix it. Okay? And that happens in medicine quite often. Okay. One last sub scenario of scenario C is that maybe they're coming in for a routine dissolving filler, right? In my practice, I try to dissolve out the lips every 2 to 3 years. And what I do in those circumstances is I just charge them the cost of the product. I charge them $100 a vial. Okay, and I let them know it could take 2 or 3. They pay $100. I'm not out any money. I don't make any money, but I want them to do that so they get the best results. So those are the times I charge. Elective reversals, somebody else's mistakes. Okay. Lastly, let's talk about consenting your patients. Do you need a specific consent form for dissolving? Not necessarily. I put it on my filler protocols. However, if they're coming in like from down the street and they're coming into your practice to get it, then I will have them sign a separate consent. I actually just have them sign my filler consent because it has all the language in there, and that way I don't have multiple documents laying around. But it needs to list the standard risk, bruising, swelling, maybe an allergic reaction. But it also like keys in them to what I call like the emotional consent, like they're buying into the process by signing that on the bottom line, right? So look at the patient, look them in the eye and say, hey, listen, I'm going to dissolve this filler. You're going to lose some volume. You might feel like you look a little deflated for a few days, or maybe a little wrinkly, a little prunish. Are you okay with that? And then have a conversation. Patients hate the lumps, they hate the bumps, but they love the volume. And if you take that volume away without preparing them psychologically, they're going to freak out. So manage the emotion up front, manage it first, then you manage the issue. All right. So stock it like insurance, charge for your expertise when appropriate. Never charge for safety. That's my 2 cents. All right. So now let's switch gears, and in our final module, we're going to put all of this to the test. We're going to run through 3 interactive case studies: a vascular occlusion, a Tyndall effect, and a migration case to see if you're ready to handle the real world. All right, so we've covered the science, the protocols, the recipes, and the business side of Hylenex, but frankly, none of that matters if you can't apply it when your patient's sitting there in your chair. So what we're going to do is we're going to put it all together now with 3 world case studies. And I want you to listen to the scenario and then decide which bucket you're in and pick your recipe. Let's see if you're ready to do it. All right. So when we get through the case, I want you to pause it and I want you to think through it before you hear our answer. All right. So case study number 1, you injected the patient's lip 2 hours ago. She calls your office in a panic. She says, hey, her upper lip is throbbing. She's got a burning pain that tends to be getting worse, not better. She sends you a selfie, and you can see from the selfie that tissue, let's say it's near the filtrate column, it looks pale white, almost milky. What is your diagnosis and what is your move? So I want you to pause the video right here, and I want you to think about that. All right. So you gave a little bit of time. What are you going to do in this situation? All right. In my world, this is what I call a code red situation. This is a vascular occlusion or a likely vascular occlusion. And you are now in bucket number one, the emergency bucket. You do not wait. You bring her in immediately. I don't care if you're at home. You bring him in and you're driving into the office as well. And you perform your capillary refill test. If that color return is sluggish, you are going to act and you're going to go with the emergency protocol. You're going to flood the field, right? Grab your 4 vials of Hylenex and start the protocol we talked about, okay? And get that stuff into them. Notify your medical director. Now, another question I'm going to ask, even though we're on the lip, is do we have any vision changes, right? Because remember, the artery might be occluded here and we're seeing a pale lip. Well, what about the eye? Are we getting blood flow to the eye? Maybe the tip of the nose. Maybe there's some other areas that are affected. If that's the case, is she coming into my office? No, I'm sending her straight to the hospital, right? And I'm calling the hospital saying, hey, I got an emergency coming to you. This patient I treated 2 hours ago with filler. She left looking great. She's now reporting we got some pale vermilion, and I'm suspecting a vascular occlusion. All right. She has vision changes. So we need to go get an optometrist in. Do you have Hylenex? Okay. And if not, you're driving Hylenex over to the emergency room. Okay. So that's what protocol you're going to do if you see something like that. Get them in the office and start working the system. All right, let's go to case number 2. A patient comes in who had her under eyes filled 2 years ago at another clinic, and she hates it. She says she looks tired. She says her eyes are always puffy, and you look closely and you see like these little puffy bags with just a hint of a bluish translucent hue. Okay, what is that hue? It looks like a bruise, but it's not. Bruises go away in a few days, right? This has been going on for 2 years. That is the Tyndall effect. The filler was placed too superficially, and now the light is reflecting off of it, giving you this pale gray blue spot. So, which bucket are we in? You tell me. We're in bucket number 2, aesthetic correction. All right. Now, if you use the emergency protocol here, you're going to dissolve that filler, but you're also going to eat through all of our natural hyaluronic acid and leave her with these hollow skeletal eyes. So I'm not going to necessarily do that. What am I going to do? I'm going to do the blur mix, right? I'm going to do super diluted, low concentration recipe, 150 units and 10, tiny micro droplets just to soften the blue hue without stripping off all the volume. And tell her it's going to take a couple, 3 sessions, and we're going to whisper to the tissue, not shout at it, right? That analogy works really, really well. I literally had this patient come in my clinic. Very first time she come in, she had these little balls right here on the side. She's like, I got under eye filler like I think it was like 5 years ago, and I got these little balls over here, and I just want to. I fixed the under eyes, but now I want to fix these balls, and I palpate her balls. I'm like, that's filler. And she's like, really? I'm like, yeah, let me dissolve it. I dissolved it right there. Instantly went away. Patient for life. Okay. All right. So that's case number 2. All right. So scenario number 3, we had a patient that comes in with the filler mustache. She has a ledge of filler that has migrated above her vermilion border. She wants those nice, crisp, tight lips she had again, 8 years ago when she first started doing filler. So what protocol are you going to use? So pause right here and tell me what protocol you're going to use. I am going to use a protocol from bucket number 2, which is you need to be a little bit more powerful than like a tear trough treatment. Okay. And so I call this the sculptor mix, your medium concentration mix. All right. So what we'll do is you're going to, draw up that Hylenex in, 1 vial of Hylenex in, 2 to 3 cc's of fluid. And you're going to inject small amounts evenly along that upper border to dissolve the lip without it migrating and deflating the entire lip itself. So I'll take a little tiny 30 gauge needle and I'll just go and just put little dabs of that dilutant right at the vermilion border, right in that perioral line, right in those problem areas without going into the lip itself. Okay. And oftentimes if you do that, that vermilion border actually is a good barrier between lip and skin. And if you inject outside the vermilion border, meaning not in the lips, it will often stay there and you can actually dissolve all that migrated area out. Tell her that she might look a little wrinkly in that area for, a couple of days. But just trust the process that's going to work, and then have her come in next week and take a look and see if you need to do it again. So, I inject that right above the vermilion border. Am I going to massage? Maybe I might massage up into the perioral or down into the perioral area if it's on the lower lip. But I'm not trying to rub it into the vermilion because I want to keep the filler that's in the vermilion there. Save her some money down the road. If it's all over the place, you might have to dissolve the whole lip out and start fresh again. All right. So injector, send her home, follow up with her next week, see if it fixed the problem. All right. So now you nailed those 3 scenarios. I think you're ready to get going. You now have a tool that makes you safer, more artistic, and honestly more valuable to your patients. So take what you learned and go apply it to your practice. Listen, I understand that an emergency sounds scary and that, learning about the bad things that can happen may make you not ever want to go down the path of doing it, because if you don't do filler, then you'll never have to deal with the complications. I strongly encourage you to not let the what ifs keep you from doing something amazing like incorporating filler in your practice. So what do I mean? I've been injecting filler my entire professional career as an injector, and I've been doing it for almost a decade. And I have never had a vascular occlusion. Why? Because I know my anatomy. And if you know your anatomy and you know exactly where everything is, you can largely avoid complications. And then I do safe injection techniques. Like if I'm near a facial artery, I will use a cannula. Okay. Or if I'm near an infraorbital foramen, I will use a cannula in that area. I only put a needle where I know it is. And so by knowing your anatomy, knowing where the problem areas are, you can largely avoid vascular occlusions. Is it a guarantee? No, everybody's anatomy is a little bit different, right? And what works for one person is not going to work for the next. But if you know, hey, I have a facial artery that goes from right here and squiggles up right on the lateral side of the nasolabial fold, I probably shouldn't be putting filler in that area, right? Versus, hey, I know if I go right to the bone right here, there's nothing much there, right? I'm on the bone. Okay. So largely knowing your anatomy will greatly reduce your chances of filler complications. And then don't inject filler in the danger areas. Glabella, you should never inject filler into the glabella. The nose, highly dangerous to inject filler in the nose. So avoid the danger areas, avoid the areas where you know the arteries are, inject in on bone or right under the skin, and you will largely decrease your chances of getting a vascular occlusion. Okay. Not to say it can't happen. You still got to be prepared. But knowing your anatomy will take you down the safe path versus a dangerous path. And if you feel like your anatomy skill set or your filler skill set isn't on par with where you want to be, remember, we have all the courses available for you to where you can do a deep dive into those courses. You can rewatch them over and over again and learn about the anatomy and proper injection technique, and you'll largely become a much more safe injector.